Hello and a very good evening to all. I, Dr. Dhammadip Dabade, on behalf of MQ Pharmaceuticals Limited, welcome you all for a scientific event by name No Thrombosis. No Thrombosis is a unique scientific initiative by the MQ based upon the discussions on the real life challenging cases of the clinical cardiology, particularly targeting or focusing thromboembolic conditions as a theme of this program. And that's why the name No Thrombosis stands for we are going to learn and understand. So this is specifically for all those viewers who are with us, join with us for this live workshop in which our major objective is to learn and understand the various thromboembolic situations typically occurring maybe in the perspectives of the clinical cardiology or the internal medical situations are concerned. So in this, with that particular objective, we will be having various eminent faculty who will be presenting their cases. And of course, there will be very wonderful discussions based upon those presentations throughout the sessions. With that note, I would like to just inform all our viewers today and all the faculty, of course, that this particular program, No Thrombosis, been awarded as the most engaging scientific platform by an Indian pharma company in the year 2021 by the 9th edition of the SIMS Healthcare Excellence Awards. With that note, our course director for this event being Dr. Vilas Magarkar sir, who is the chief Department of Cardiology and Interventional Cardiologist at St. Nandladus Hospital, Aurangabad. I would like to introduce and welcome for this particular event our course moderator for this today's event, Dr. Gaurav Verma sir. Dr. Gaurav Verma sir is the interventional cardiologist been affiliated with the SMBT Hospital, Nashik. Now, I would like to welcome our first speaker for today's workshop, Dr. Deepak Kuble, who is the consultant interventional cardiologist affiliated with the Parbhani ICU and Super Specialty Hospital, Parbhani. I would like to welcome our next speaker for this event, Dr. Rajesh Wagh, who is the consultant interventional cardiologist affiliated with Wagh Heart Care and Specialty Clinic, Pune. I would like to welcome and introduce our third speaker for this today's event, Dr. Amar Amle, who is the senior interventional cardiologist affiliated with the Dr. Amble's Heart and Health Clinic, Nagpur. So this will be the agenda today. We will be having the opening remarks from our moderator, Dr. Gaurav Verma sir, and which will be followed by the case presentations one by one. As I mentioned, we will be having 3 speakers. Each case presentation and the discussion will be lasting for 15 to 20 minutes. And so presentation will be followed by the discussion. With that note, I would like to stop here and would like to hand it over to Dr. Gaurav Verma sir, who joined with us today. Over to Dr. Gaurav sir. Thank you.
Hello, hi, welcome, thank you, and I welcome all the participants for this no clot thrombosis workshop. And we all are, having this workshop since last 6 months probably, and we are getting enlightened every time when we, discuss the cases presented by the speakers. And today we have 3 eminent speakers, and let me invite our first speaker. Is Dr. Wagh first? Is it?
No, Dr. Deepak Kuble will be the first.
Deepak Kuble will be the first speaker to tell us about what he wants to say about the CAD and peripheral vascular disease about his patient. So let's first invite Deepak Kuble. Deepak, welcome, and just go on and take over the mic.
Thank you, sir. So just I will share the screen.
Please.
Yes. The presentation is visible?
Yes, doctor.
Yeah. So basically, it is a case of acute pulmonary embolism. Now, depending on the case scenario, we'll discuss how to approach the case of acute pulmonary embolism and what are the challenges faced in management. So this is a 35-year male patient who came to our emergency room with a grade 4 NYH SOB, and he has a history of left lower limb pain since 3 days. However, there was no swelling on history. There are no comorbidities. He is a non-smoker, non-diabetic. There is no obesity, and there is no history of any trauma or recent surgery. So on arrival, his pulse rate was 120 beats per minute. His blood pressure was 80 by 60 millimeters of mercury. His respiratory rate was 32. Saturation is not mentioned, but it was 80% on arrival. And on auscultation, the chest is clear. So immediately blood was taken for routine parameter testing as well as special tests. ECG and echo done there in the ER only. So the ECG here you can see it is showing a tachycardia. The axis is looking normal. You can see significant S wave in lead 1 as well as there is a small Q wave in lead 3 as well as a T inversion. That's a classic S1 Q3 T3 pattern compatible with the acute pulmonary embolism. And this was a short echo what we have recorded. It is showing a right atrium and right ventricle dilated as well as a hypercontractile approach. That is a classical McConnell signs that is seen in the acute pulmonary embolism. So here you can see the hypercontractile approach. Overall, the global contraction of RV is reduced and RA-RV is dilated. So other findings in pulmonary embolism you can see are the dilated RA-RV. And then the septum may be flat, IVC may be congested, there may be TR. Significant TR may be there. The reduced TAPC may be reduced to less than 60 millimeter. His X-ray is clear except from the dilated right descending pulmonary artery. Everything looks normal. Blood parameters, the hemogram is okay, creatinine is okay. D-dimer levels are consistently on higher side. It is in the 3867. Troponin I is strongly positive. So how to approach this case? Basically, there are a few questions here. So first, we have to calculate the probability of a pulmonary embolism in such cases. Then depending on the probability, how to approach for further management and which test to use for the diagnosis for the pulmonary embolism. Once you have diagnosed the embolism, now you have to stratify the embolism into different groups like high risk, intermediate or low risk. And depending on the risk category, how you will treat the case. Then once you have treated the acute phase, how you will approach this case in a long-term basis with the anticoagulation, and how to do a follow-up visit and rule out any CTPH in the follow-up. So these are the questions in this case. So the first question was to calculate the probability of embolism. So we have the two scores with us. That is, one is the revised Geneva clinical prediction score. So it has multiple parameters. Everyone can go through the score online. So for our patient, the score was around 8. So 8 comes in the high probability. Revised Geneva clinical prediction rule for the embolic pulmonary embolism. Second score is a Wells score. Wells score also, if you calculate the Wells score for our patient, it is 7.5. So definitely it is in the high probability. So our case, Geneva score was 8, Wells score was 7.5. So both scores suggest that there is a very high probability of pulmonary embolism. So now we have come to a conclusion that it is possibly very high risk, high chances that it's a significant pulmonary embolism. Now we want to do further testing, and which test we'll choose based on the probability. So this chart is suggesting here. So directly, if you see there is a high probability of pulmonary embolism, you go ahead with the CT pulmonary angiography. And suppose the probability is intermediate or low, we can do a D-dimer test. Depending on the D-dimer value, we can go ahead. If it is positive with the CTPA, if it is negative, we can just observe the patient for further complication. So in our case, as it was a high risk pulmonary embolism, we have done the CTPA. So here you can see the report of CTPA. The diagrammatic depiction has been done by the radiologist, which is showing a huge thrombus, almost a saddle thrombus that is in the MPA as well as extending into the both RPA, LPA and the segmental branches. So it is a huge thrombus. So the basically CTPA, if you are using this in a low or intermediate probability cases, it has a high negative predictive value. So that means if the CTPA is normal in a low or intermediate category PE suspected patient, you can surely rule out the pulmonary embolism. And this almost its sensitivity, the specificity is around 96% for detection of the pulmonary embolism. So again, we have done the DVT screening because he has history of 3 days pain in the left leg. So it is suggesting almost completely occluding thrombus in the left SFA popliteal vein as well as the proximal tibial and the proximal peroneal veins. So basically, it is suggesting a huge thrombus burden in the leg, including the proximal involvement of the this femoral veins also. So, some recommendations regarding the lower limb compression ultrasonography. So these recommendations are based on the this recent 2019 pulmonary embolism guidelines given by the European Society. So as per the European Society, if you don't have any facility of CTPA, then probably you can use this tool to diagnose the pulmonary embolism. If the compression ultrasound is showing the proximal DVT, that is in the SFA or in the iliac veins or in the IVC, probably you can consider as equivalent to the diagnosis of pulmonary embolism if your patient is clinically findings are consistent with the that of the pulmonary embolism. So you can definitely use this test more often in a pregnant woman where probably X-ray and CTPA are probably that much not safe. So then again, now we have come to a conclusion that the patient was probably having a pulmonary embolism. Then we have done the CTPA. It has shown that there is a definitive a massive pulmonary embolism. Now we have to risk stratify the patient. So how to risk stratify a patient of a pulmonary embolism? So there are scoring system based on this PACE. PACE is the pulmonary embolism severity index. So depending on different points given to here, almost our case is showing the 100 point total score is 100. So 100 comes in the class 3. Class 3 is showing a moderate mortality, that is 3.2 to 7.1%. So using this PACE score, now this is the chart given by the European Society to stratify the patients of pulmonary embolism into 3 categories, whether high risk, intermediate risk or low risk. So high risk, you have to see the parameter, hemodynamic instability. Our patient was having a BP of 80. He was on NORAD, so he is hemodynamically unstable. Then this PACE score. PACE score is 100. It is class 3. So it is positive. RV dysfunction was there on the echo. And again, this positivity of the troponin. All these 4 parameters suggest that our patient is a high risk category and a very early mortality is very high in such patient. So depending on this chart, you can stratify the patient into high, intermediate or low risk. So depending on this category, we can further treat our patient. So as our patient was a high risk, so this chart is suggesting that how to approach the patient according to their mortality risk. So the high risk patient should be thrombolized. High risk patient should be thrombolized if there are no absolute contraindication for the thrombolysis. Then intermediate risk patient. So intermediate risk patient also you can stratify into 2 groups, either troponin positive RV dysfunction, it can be a intermediate high risk, and if the troponin and this RV dysfunction is not there, it can be an intermediate low risk. So intermediate high risk patient can deteriorate further, so you have to watch them closely. If they are deteriorating, you have to thrombolize. If they are not deteriorating, you can manage off with the anticoagulation alone with the LMWH. And the patient with a low risk patient, you have to definitely start oral anticoagulant. If the patient is having good facilities available and hospitals are nearby, you can send them home on oral anticoagulant. And suppose the patient is far from the rural area, you can just observe him for time being in hospital and give the LMWH or the Fundopirinox. So acute phase treatment, given the treatment, everybody knows the patient is hemodynamically unstable. You have to support the patient. Sometimes there is a very huge, massive this pulmonary embolism. You have to use the ECMO or EMPAL also. But probably this is not easily available in our area. And the thrombolysis is the main line of the treatment. So maximum benefit of the thrombolysis is whenever the patient presents within the 48 hours. And you have to assess the patient periodically. Suppose there is no hemodynamic improvement, there is no RV function improvement, then it can be an unsuccessful thrombolysis. So these different molecules, everybody know what we can use for the thrombolysis. Then unfractionated heparin should be used for all patients. NOAC should be considered over the vitamin K antagonist in all patients with a pulmonary embolism. Suppose the patient is having antiphospholipid antibody syndrome, you have to give the warfarin or the acetrom instead of the NOACs, and you have to maintain the IRR in the therapeutic range, that is 2 to 3. Then whenever the patient is having any absolute contraindication for thrombolysis, or a patient is having a failed thrombolysis, you have to go ahead with a surgical embolectomy, or you have to use with a percutaneous catheter directed treatment. Then regarding IVC filter, routine use is not at all recommended for the IVC filters. IVC filters are only indicated in those patients where there are some contraindication to the anticoagulation, or those patients who are on the anticoagulation, but still, despite being on anticoagulation, they're having recurrent episodes of the pulmonary embolism. In these cases only you have to use the IVC filter. Otherwise, the routine use is not at all recommended. So this is some so after the treatment, what are the chances that the PT or the VT may recur? So there are multiple factors. The patient is having a cancer therapy. There are antiphospholipid antibody syndrome. Usually these patients usually are at a very high risk of recurrence of the thromboembolism. Then regarding the long-term anticoagulation, what we have seen now, that thrombolysis anticoagulation therapy, that is for the acute cases. Now how to approach for a long-term anticoagulation? Suppose usually for all patients with a pulmonary embolism, at least you have to give a 3 months therapy with the newer anticoagulant. So beyond 3 months, which patient you want to continue? Those patients who are having a recurrent DVT or recurrent pulmonary embolism, and you cannot find a major transient cause, or there is no reversible risk factor, you have to consider this patient to give almost indefinite anticoagulant oral therapy. Then in antiphospholipid antibody syndrome, you have to give a prolonged anticoagulant therapy with VKs. Then this was for recurrent, but what for the patient with first episode? Those patients having a first episode of pulmonary embolism, and you don't find any identifiable risk factor. In this patient, it is not a class 1 recommendation beyond 3 months. It is a 2A recommendation by the AC guideline. And whenever we are continuing the NOACs for the prolonged period, if you are using a rivaroxaban, you have to use 10 milligram, and if you are using this bixaban, you have to use 2.5 milligram BID. So these are the guidelines regarding the long-term use of the antithrombotic therapy. In cancer patient, it is slightly different. If the patient is having an active cancer, you have to use the LMWH over the NOACs for the at least 6-month period from the diagnosis of the pulmonary embolism. Suppose there are some issues with using LMWH, you can go ahead with the use of NOACs, and preferably you can use either rivaroxaban or endoxaban. Endoxaban is not available in India, so the rivaroxaban is the only molecule in active cancer patient for first 6 months. But you have to rule out any active GI bleeding or any active gastrointestinal cancer. It is very difficult to give rivaroxaban. Suppose the patient is pregnant and having pulmonary embolism, what to do now? Many tests are contraindicated or at risk to fetus, such as X-ray or the CTPA. So probably you can use a compression ultrasound in such cases, or a very high risk patient where the patient is deteriorating rapidly. You can do a CTPA also with a due caution, or use abdominal shield. In most of the patient, I think in first trimester, last trimester, you have to use a LMWH. And initial therapy is LMWH definitely, but for long-term management, in the mid trimester, you can use warfarin. Otherwise, LMWH is the only therapy in pregnant patients. So all patients pregnant patients should receive LMWH at least. And if the patient is having massive embolism and deteriorating rapidly, you can go ahead with a surgical embolectomy or the catheter-directed thrombolysis. And in many patients, you have to also rule out the amniotic fluid embolism, because anticoagulation therapy will not alter the course of this disease because of the amniotic fluid embolism. It is totally different etiology. So patient may be pregnant or patient may be postpartum, but still sudden deterioration may suggest the amniotic fluid embolism. So a long-term sequelae of pulmonary embolism. Now you are treated the long-term with anticoagulation therapy. Now how to approach for the follow-up? So the risk factor, the most complication that can happen with patient of pulmonary embolism, it may get organized and become a chronic thromboembolism. So what are the risk factors for thromboembolism? It may be a recurrent pulmonary embolism or recurrent DVTs, or the initial load of the thrombus is very high on initial CTPA or initial RV dysfunction, that are most commonly associated with long-term development of the chronic thromboembolism. So how to monitor this patient? So you have to definitely give 3 months of effective anticoagulant therapy. At the end of 3 months, you have to do an echo. So echo, you can assess the right ventricular systolic pressure, TR jet velocity, you can assess. But ideally, if the patient you are suspecting on echo that is having a pulmonary hypertension, you have to subject the patient for the right heart catheterization. In right heart catheterization, if the mean PA pressure is more than 25 and the wedge pressure is less than 15, probably the patient is having a chronic thromboembolic pulmonary embolism. And in such patients, you can evaluate further with the use of the CT pulmonary angiography or the perfusion scan. So on perfusion scan, if there is perfusion defects, probably it is a CTPH. And on the this CT, angiography, you are getting a ring-like stenosis or web slits, probably it is a chronic occlusion. Many times it becomes very difficult to recognize whatever is the acute occlusion or old occlusion on the CT angiography. So better to go ahead with the this pulmonary perfusion scanning. So in many patients of the CTPH, you have to go ahead with the surgical treatment. That probably is the better. That is pulmonary endarterectomy. You have to choose the patient very cautiously. Another treatment options are the balloon pulmonary angioplasty. And suppose if the patient is not suitable for both, you can go ahead with the use medical management like diuretics. You can use home oxygen therapy. You can use, or the REOC got, that is a class 1 indication now, that you can use. And these patients will require lifelong anticoagulation. Probably better to use the VKs in such case, patients with the chronic thromboembolism. Then follow-up strategies. Follow-up, usually we ask the patient to follow up after 3 months to 6 months, and we ask for the symptoms. The most common symptom is the dyspnea. If the patient is not having dyspnea on follow-up, echo is normal, probably you should just continue the anticoagulation based on his risk. And if the patient is having any secondary thromboembolic episode, you can stop the anticoagulation after 6 months. A patient is having dyspnea, echo is showing PH, you have to rule the possibility of CTPH by doing a VQ scan or the CT pulmonary angiography. If the both scan are negative, you can just follow this patient over the period of time. Otherwise, if the scan are positive, again you have to refer this patient in a specialized center where they are managing the chronic thromboembolism. So this was a short presentation regarding the pulmonary embolism and its management. Thank you.
Hi, Deepak. You presented nicely. You just gave us the overview, how do we manage pulmonary embolism, but you didn't tell what did you do with your patient.
Yes, sir. This patient was recently discharged. So he was discharged on the...
No, but what did you do? Did you thrombolize?
Yeah, sir. The patient was thrombolized. Patient improved.
What did you do? What thrombolytic agent did you use?
I have used tenecteplase as per the body weight, sir.
But
his body weight is around 56. So
but tenecteplase is not in any guidelines. Do you know this?
Yes, it is not in the guideline. Guideline only recommend presently 3. But right. Because bolus administration and ease of administration, we have given that, sir.
Right. And did you repeat CT angio?
Sir, just recently he got discharged last week. So we are planning at the end of 3 months, sir.
Fine. Suppose now another question is like, suppose if the patient was hemodynamic stable.
Yeah.
But your CT was the same, what you CT showed. CT angio report is the same, what you have mentioned now. Then what would be have been your would be your approach then?
Yes, sir. Based on this CT report, just hemodynamic instability, this other parameters, if we consider Ivc score and echo findings and the troponin positivity, I would still have thrombolized considering the massive thrombus load.
Now, this is what is the point of discussion, that when we have a clear-cut hemodynamic instability, what makes the patient into a high risk of pulmonary deterioration and high risk of the probability, then we thrombolize. But if the hemodynamics are stable, like the blood pressure is 100, even if there's a RV dysfunction, the CT shows some massive pulmonary embolism, it comes into intermediate risk of pulmonary embolism, right? Then the guidelines changes, because what has happened is it is not like MI, that whenever we have MI we thrombolize, and thrombolize is the grade class 1 indication for STEMI, right? But with pulmonary embolism, what has happened with all the trials, what has happened in the past, there were around 10%, 9 to 10% bleeding risk, with 1% intracranial hemorrhage risk with thrombolysis. Out of this, all the newer, the Alteplase or, the urokinase, the trials have shown that if you compare it with heparin, except in hemodynamic unstable patients, the results are almost similar.
Okay.
Right? So if the patient is in a moderate risk category, like when the patient is hemodynamic stable, echo shows RV dysfunction, the PA pressures are around rule of 55. You must be knowing that the PA pressure are 55, dimension 55, and McConnell sign is positive. Patient is having some massive pulmonary embolism. Saturations are around 90. Then he comes into an intermediate group of risk, right? In such cases, now the opinion is divided. Like you said, that you would still go with thrombolysis, but the risk of having a bleed is much higher. So at that moment, what we decide is the risk of bleeding of the patient, the general condition of the patient, how is stable he is maintaining. We observe for 1 hour, And still, if you want to go do thrombolysis, then CDT. There was a trial by the name of MAPET 3,
Yeah.
which has shown that when you have an intermediate class and you do catheter directed thrombolysis, the risk of bleeding is less. You have more early recanalization with the in situ thrombolysis. And third, the post thrombolytic sequelae or the CTP, that means the chronic thrombopulmonary embolism, the syndrome is also less with thrombolysis. These were the only benefit, but in hospital mortality and the symptom benefit were similar. But having said that, when you talk about CDT or catheter directed thrombolysis, the dose required is lesser. You directly visualize the artery, and you have also if the patient is not that stable or quite old to be shifted, for the CT scan and Dopplers, you can directly see, visualize yourself inside the lab, and if need arises, you can thrombolyze. This is one point. Other is, suppose the patient comes in high risk category and has a history of bleeding ulcer, maybe or bleeding piles. Then what would you do?
Yes, sir. That absolute contraindication, relative contraindication still stand for the pulmonary embolism management also. So they are almost like, if you are thrombolizing in either MI or P, that guidelines you have to look for the absolute contraindication. Active piles, I think it does not come under absolute contraindication. So
no, that again you have to be very careful. If the patient has a good history of bleeding through piles or history of hemoptysis before, you have to be very careful. And again, the CDT. My point of discussion here is that CDT has a very important role rather than thrombolysis. We have a very short threshold for thrombolysis in pulmonary embolism, but actually, if you see the type of patient what comes to us, usually only 5% or 10% comes in very high risk or hemodynamic unstable. Other, usually I must say that 50% come into moderate risk. So you have to have a very high threshold for thrombolysis, for the simple reason that when we thrombolize and the patient bleeds, then we have no option to stop the bleeding. So even if the patient have a high risk with the borderline hemodynamics which are not getting controlled with inotropes, you have the option thrombolysis. But if you can do catheter directed thrombolysis, you being an interventional cardiologist, it's very easy for you to go directly in the pulmonary vasculature, see for yourself how much is the burden, thrombus burden, both the side, and give very less, 1/3 or half the dose of tenecteplase place what you use. And of course, even in our setup, we use tenecteplase place only because of the simple reason of the availability, better result than streptokinase and less side effects. Altiplase is costlier and also availability issue in many areas in the periphery. So what I want to stress is that, of course, for high risk or the patient who are hemodynamic unstable, thrombolysis, systemic thrombolysis is a choice, but you should always consider CDT or catheter thrombolysis, which are now coming into guidelines. We still don't have direct guidelines for CDT in the class 1 indication. Still a 2A indication, and that too very high risk patient, or when the patient come into intermediate group, then we have the choice to do CDT. Otherwise, the systemic thrombolysis is the class 1 indication. And other thing is the risk dramatically decreases with CDT or with systemic thrombolysis. The difference is that the bleeding risk is markedly less. The results are the similar. So whenever possible, if you want to thrombolize, if we don't have option, then definitely we have no things to, and we do systemic thrombolysis. But we have seen patient getting bleeds with the systemic thrombolysis, although the pulmonary embolism improves, but sometimes the patient do have the cerebral hemorrhages and other sites of bleeding. So still, except for very high DVT, where still in situ thrombolysis is highly preferred rather than in pulmonary embolism, in which we fear bleeding. So all the trials that have been done in the past for the pulmonary embolism, they are not that pro for thrombolysis. So we should have a very high threshold for thrombolysis. And heparin, a 24-hour infusion, and whatever dosage you have discussed, have almost similar result in terms of the hospital deaths and morbidity. Although the chronic syndrome, chronic pulmonary embolism syndrome, is much more with the heparin arm rather than thrombolysis arm, but the bleeding risk always preclude us that we should be slightly having higher threshold. And CDT, for the benefit of using less dose, less effect, good result, is always the option. And of course, we all know that when the probability is less or the patient comes in the lower risk, When there's a minor peripheral pulmonary embolism, then we don't thrombolize. We usually give heparin, or nowadays we directly start with NOACs, right?
Yes.
So another question, Deepak, what NOAC did you give and why to this patient?
Sir, actually, for the cost purpose, we are given the rivaroxaban in their standard dose, and availability is also widely available in our area. That apixaban is quite costly. Dabigatran usually the compared to the rivaroxaban slightly higher bleeding risk, so I have avoided. The safest one is definitely the apixaban, but the cost is very high.
Right. And other important thing is that if the patient has a lower risk of lower risk with pulmonary embolism, then we even don't give heparin. We directly start with rivaroxaban, like what we do with DVT. But in your case, definitely we have to thrombolize first, give heparin after that, and then we start with either NOACs or a vitamin K antagonist, isn't it?
Yes, sir.
Any other questions?
Sir, no further question. Can we proceed for the second?
Yes, sure. Is it Dr. Rajesh Bag's
Yes, exactly.
now turn?
Yes, sir. Dr. Rajesh,
Hi, Rajesh, are you ready?
Yes, I am ready, sir.
Okay, let us invite you and let's pass over the mic to you, and you just take over the proceedings now and just present your presentation.
Okay. Can I get my presentation?
Yeah, 1 minute, sir. Just
Okay.
1 minute.
Okay. Fine. Okay.
So this is the right.
Okay. Yes. Right. Same. Perfect.
Can maximize, Ravi. Yeah.
Yes.
Okay. Perfect. So actually, it's most commonest and most everybody's day-to-day patient. Case study of particular CAD who has more than 3 and hemorrhagic stroke. Okay, so let's proceed with the case. So presence of atrial fibrillation is associated with 5-fold increased risk of stroke that everybody knows. Subsequent diagnosis of ischemic stroke. Subsequent diagnosis of ischemic stroke and atrial fibrillation significantly increases mortality risk. Paroxysmal AFib may not be clinically evident in a patient with ischemic stroke on admission. This AFib may be present for many years prior to presentation. Atrial fibrillation is recognized as a major risk factor for stroke, and there is 5-fold increased risk of stroke and is devastating with serious comorbidities and mortality. It is important to recognize at early as stroke prevention is vital, and data is clear on the use of NOAC in stroke prevention. Next slide. So definitely this is a case of 79-year-old elderly gentleman presented with history of left-sided weakness and unsteadiness of gait for 12 hours duration. This educated patient has been on treatment for diabetes and hypertension for 10 years and was fairly well controlled on metformin and metoprolol. His family physician, I don't know his name, but has diagnosed him with erratic heart rate a year ago and was just started on clopidogrel. And metoprolol 25 mg morning and evening atorvastatin 10 mg was started. So clopidogrel 75 mg once daily and metoprolol 500 mg daily. Next slide. So on clinical assessment, this patient, he had heart rate of 82 beats per minute that was irregular. BP was 150 by 80. GFR was 48 ml per minute. He had complete left side flaccid paralysis and extensor plantar. ECG was showing atrial fibrillation with controlled rate. No ischemic changes. So his lab parameters are almost normal with creatinine of 1.3. So his GFR was 48.6 ml. His emergency CT was done. It was showing large acute non-hemorrhagic infarct in right ICA territory infarct. So there was a MRI angiography was later done, which was showing complete thrombosis of right vertebral artery with thrombus and mild luminal narrowing of basilar artery. So definitely on admission, this patient's CHAD-VAS score was 5 and HAS-bleed score was 2. As patient presented more than 12 hours, he was not a candidate for thrombolytic therapy. So neurophysician said that we will not be doing thrombolysis for this patient. And as usual, antiplatelet, statin, beta blocker, ARB, and OHA were started. Next slide. So on diagnosis, he was diagnosed as a diabetes, hypertension, atrial fibrillation with control rate with acute hemorrhagic infarct. His neurological status remained same and repeat CT 5 days later showed no further progress. So he was treated in addition with rivaroxaban daily. So after 5 days, CT scan was repeated and that CT scan does not show any increase in size of infarct. So he was started on rivaroxaban 20 milligram daily. Next slide. So he had 2 hospital admissions after follow-up. After recurrent follow-up, he had 2 hospital admissions for cholecystitis 3 months later and needed elective laparoscopic cholecystectomy. And again, year later, he developed transient syncope and Holter detected atrial fibrillation and multiple episodes of pauses. So rivaroxaban was stopped for 2 days and he underwent pacemaker and was restarted on NOAC after 3 days. There was no bridging for heparin was done and he had completely uneventful course. So he was doing well on NOAC, OHA and antihypertensive. Next slide. So starting NOAC after ischemic stroke depends on stroke severity and area of infarct. So small infarct, it can be started as early as 3 to 5 days and 10 to 12 days if later for a larger infarct. Discontinuation of NOAC to non-cardiac surgery is crucial, but for elective procedure, it can be discontinued 48 hours prior and bridging with heparin, LMWH is not recommended. And it can be safely started after 24 to 48 hours once bleeding is controlled. Renal function needs dose adjustment and that has to be known for everybody should know about it. Next slide. So key message is that AFib once identified needs meticulous workup and treatment based on guidelines. NOACs are integral part of stroke prevention. Decision to start anticoagulation depends on infarct size and severity. Discontinuation and restarting for non-cardiac surgery is very, very feasible and easy. But dose titration is needed for renal impairment. But if for renal impairment, if GFR is above 50, then there is no need of dose reduction. If it is between 15 to 50, we can reduce it to up to NOAC 15 milligram per day, and less than 15 ml, ideally, these drugs are not recommended if GFR is below 15. Next slide. Thank you.
Hi Rajesh.
Yes, sir.
Nicely you told that how do we start anticoagulation with AFib and stroke patient. Can I have the first slide of his presentation, please?
Yes.
First, before this.
Yeah.
Back. It was not hemorrhagic stroke, right?
Actually, it is ischemic stroke. Headline is actually hemorrhagic stroke.
So this incites one question that if the patient is there's a hemorrhagic stroke with CHAD-VAS score more than 3, what will you do?
Yes, it is very tricky question, but still, once the hemorrhagic stroke is there, we can wait for at least 1 month, and then even for hemorrhagic ischemic stroke which had developed hemorrhagic transformation, still we need that after 1 month.
Now, Rajesh, just I had witnessed 2 or 3 these symposia on NOAC just recently. So what the latest guidelines are that first you evaluate why the hemorrhagic stroke happened. I'm just, this is out of the context of this because it was written hemorrhage. So it came to mind, so I'm discussing. I'll come to this topic again. So first is, whenever you have a hemorrhage, right? First we evaluate why the hemorrhage occurred, whether it was a hypertensive bleed, whether it was because of the patient on antiplatelets. Third, whether it was because of without any reason patient presented with stroke. Then whether it was because of the anticoagulation. Why? Because the strategy, the management is totally different. Why different? Because if it is like sudden without any precipitating factor, patient had a stroke, that means patient must be having some aneurysm. Patient must have had some underlying factor for bleed which has to be evaluated. So that is different. Second, if the patient was a hypertensive bleed or was on antiplatelets and has bled, and if the size is just less than 3 millimeter, then you can start with NOACs for anti-AFib or some other indication, like patient has some other persistent indication for anticoagulation after 7 days also. The newer neurological society have suggested that at as early as 7 days we can start with the anticoagulation if the there is no underlying reason for bleed or the patient is having a compelling indication to start this anticoagulation. Second, if the patient had a bleed with the anticoagulant, the patient was on VKs or NOACs and has bled, so then you have to wait for at least 3 to 4 weeks before you should think starting with NOACs, and they recommend that you start with a lower dose, but if the patient has a compelling indication, you should start with NOACs. This is one part of the thing. Other is like in your case, that the patient is having a atrial fibrillation with stroke. So if the patient had this transient AFib and the patient had a stroke, like what you showed, a PCI territory stroke, it was a posterior circulation stroke, and now the AFib has disappeared. What will you do then?
Definitely, even if the atrial fibrillation has disappeared, still we have to consider adding NOAC for this patient because paroxysmal AFib is more dangerous for developing stroke.
Right. So now what I want to suggest was that you're right that we should give NOACs, but 3 things are important. One, the frequency of having palpitation or documented AFib, like your patient had a documented AFib and had a stroke. When it has only a paroxysmal stroke, you need not give NOACs. But when the patient has a end organ damage like a stroke, then it becomes a compelling indication to start NOACs to prevent a further episode of stroke. So having a documented AFib or intermittent or paroxysmal AFib with a stroke still becomes an indication to start with a NOAC. Right. So now the next question is, suppose the patient has a high bleeding risk score. The has bled score is now higher. Then what will you do?
If has bleed score is high, still we can consider, but by reducing the dose of rivaroxaban, or we can simply add ecosprin or clopidogrel for these patients if has bleed score is very high.
No, Rajesh, first this antiplatelet has no role. Just make it very much clear that
otherwise we have to start with lower doses.
No, even lower dose is there no recommendations for that. So why am I telling you is that whenever we calculate the Chadwick score or Has-Bled score, the parameters are usually similar. Both they have age, both they have the drug history, both have the diabetes, both have almost a similar factor what we weigh. So in this scenario, there is another score by the name of Garfield score. Have you heard of that?
Yes, Garfield score is there.
Garfield score, was developed by Dr. Keith Fox. You must be knowing him. He's a pioneer in doing all the trials, and especially for rivaroxaban. He was a chair in the Rocket AF study and many other trials. He was a chair, and he has developed this Garfield score, and this not only will tell you that the risk of having a stroke or complication like what Chadwick score tells us, but additional advantage with Garfield score is 2. One, it will itself tell you how much is the risk of bleeding. with the NOAC what you're starting. Second, it can also tell you the risk of bleeding with NOACs or vitamin K antagonist if you start both. If you have to start either of them and you calculate Garfield score, then you can judge by this scoring that which will be safer for this patient. Of course, with a high risk patient, like the patient who has a tendency to bleed, earlier history of stroke, then always we start with a safer anticoagulant like NOACs rather than this or vitamin K antagonist. But sometimes when the patient has some comorbidities like renal dysfunction, then apixaban become a better choice.
Yes.
And that too in 2.5 milligram BD dose rather than 5 milligram BD dose to prevent the bleeding risk. Right. Third important part, what I wanted to stress was about the weight. We never talk about the weight whenever we prescribe anticoagulation because no guidelines have suggested that according to weight we should decrease the dosage, right? Because in West, whatever the trials they have done was around the middle weighted people what they have taken. But in Asians or especially in Indian, we do have a very thin built patient who the weight is very less. So again, the Garfield score comes into in this picture. It's very handy because it takes the consideration of weight as well. Right. So for your patient, ideally, what you have suggested that NOACs are the preferred line of drug, but sometimes we need to start on warfarin or VK antagonist for the simple reason that we have to be monitoring them very carefully with INR, because with the NOACs we don't have any monitoring method. And the patient bleed, that will be lethal. So sometimes when we have some comorbidity associated and we fear bleeding, then sometimes we can start with a lower dose of warfarin and can titrate to the borderline targeted dose of INR around 2 or 1.8. That will also suffice. Third important point which I wanted to emphasize was that how do you follow up these patients? Like your patient had stopped, for a pacemaker you stopped NOAC, but I don't think NOAC need to be stopped for VVI. Why did you stop that?
Actually, for only 2 days, I stopped and then started after 24 hours.
But I don't. Do you think that
some fear of bleeding?
But I think it is from now onward you don't stop this because people don't bleed too much, because there's always a risk of atrial fibrillation, and atrial fibrillation risk is much more when the patient has in between stoppage period. Right, when the patient stops and then start, that is the most vulnerable period for the patient to stop. Rather than that. Third is, did you do T to see for any clots in early appendage?
No, T was not done for this patient. T was
because the most common cause of stroke atrial fibrillation is early appendage clot. You must be knowing this. So whenever you find stroke atrial fibrillation, always do T in your investigation parameters, because that will help you to stratify that whether the anticoagulation frequency or the dosage need to be increased or not. Finally, when the patient is stable after a certain duration of anticoagulation, then we may decrease the dosage. There was a study, I just don't remember now the name, but with the apixaban they have done is that instead of 5, they came to 2.5. With rivaroxaban, they did 5 milligram and patient did well. So after a certain duration, maybe it is atrial fibrillation with stroke, after 1 year, you can start decreasing the dose as well. Okay. So these are some points which I wanted to highlight. Anything else? Anybody wants to add to this?
No, sir. I think we should go for the
Sure. Let's move further. And this Dr. Amar's turn, probably?
Yes, sir. He's the
Hi, Amar.
Hi. Good evening.
Hi. Go on.
So, good evening, everyone. Myself, Dr. Amar Amle. I'm an interventional cardiologist at Nagpur. I'm going to have a case-based discussion on CAD with peripheral artery disease. Next slide. So we have a 61-year-old male patient with chest discomfort on exertion with NY 6 years class 2, and along with that with a history of claudication from 1 year. Next slide. So he has angina symptoms with claudication symptoms, suggestive of coronary artery disease and peripheral artery disease. In past history, he is diabetic and hypertensive with ischemic heart disease, who has underwent PTC and stenting with LED 12 years back and CBG 10 years back. Again, PTC with stenting to RC 3 years back and diffuse atherosclerotic disease of bilateral lower limb. These are his clinical findings. On investigating, ECG showed LVH with strain pattern, echo showed mild LV dysfunction. while Doppler study of lower limb showed diffuse disease of anterior tibial and posterior tibial vessels. Coronary angiogram showed a patent lima to LAD and SVG graft, and LAD and RCA total occlusion, which are the native diseases. Next slide. So his grafts are patent, but he has diffuse distal disease in the lower limb. So the diagnosis was coronary artery disease with patent graft and peripheral artery disease, which is diffuse type. Next slide. So he's on following treatment: aspirin, rivaroxaban 2.5 mg, statin, metoprolol, ramipril, ranolazine, and gliptin and metformin for sugar. Next slide. So we all know patient with CAD remain at high risk of ischemic events. So the REACH registry showed that only as per the risk factors and as per the stable atherosclerotic disease, the cardiovascular death and MI, risk and stroke of over the period, it goes on increasing. Next slide. So they studied around 64,000 patients. The current medical vascular protection comprises 4 pillars. The main is the lipid lowering in the form of statins, and the ezetimibe and PCSK9 is the latest drug, which is the monoclonal antibodies, which brings down the LDL to the lowest possible level. Then we have the good blood pressure control with ACE and ARBs, beta blockers, diuretic and cancer channel blockers. Good glucose control, we all know the latest drugs available, and anti-thrombotic agent protection with the form of aspirins and dual antiplatelet. Along with that, all of the patients require lifestyle modification. So do we have a scope of improvement with current anti-thrombotic regimes? Let's see. Next slide. So the newer anticoagulation, NOACs, which are dabigatran, apixaban, and rivaroxaban, we know how they act on factor 10N and factor 2A. Next slide. So the rivaroxaban, which is factor 10A inhibitor, it has been demonstrated its role in CAD. The indication for oral anticoagulation, atrial fibrillation, or high risk feature of life-threatening bleeding anemia and history of spontaneous major bleed has been mentioned. And we are done for a stable CAD on aspirin monotherapy, the history of multiple CAD, MI more than 1 year and more than 20 years. And yes, there is a role of aspirin plus rivaroxaban 2.5 mg twice a day. While the patient who was admitted with MI and treated with DAPT, then such patients, if he undergoes a PCR, then he will require dual antiplatelet. And later on, we can put him on the rivaroxaban after duration of dual antiplatelet gets over after 1 year. Next slide. So stable CAD, aspirin and rivaroxaban is recommended for 2.5 mg BD, while in patient undergoing coronary revascularization in the form of angioplasty or a bypass after ECS, we recommend dual antiplatelet. The latest guidelines as a second antithrombotic for selected patients. So this is very important. The selected patients with chronic coronary syndrome, they recommend adding a second antithrombotic agent to aspirin for long-term secondary prevention. It's a fact as type 2A, class 2A indication, considering patient with high risk of ischemic event and without high bleeding risk. So bleeding risk should be negated, and then only we should add this novel anticoagulant. High ischemic risk is defined as diffuse CAD, at least one of the following: patient having diabetic, recurrent MI, peripheral artery disease, CKD with eGFR of 15 to 60. So at least one of the following should be there to be defined as high risk of ischemic event. Moderate, at least one: multivessel CAD, diffuse diabetes, recurrent MI, heart failure, and CKD with the same GFR. The dual pathway inhibition targets of both antiplatelet and persistent thrombin generation in chronic CAD. In acute phase, the prevention strategy is dual PT, while in chronic phase, the prevention strategy is single antiplatelet or DPI. So prolonged thrombin generation is there. Antithrombotic for secondary prevention trial based has been mentioned in various trials like Capri, Charisma, Pegasus, and Compass trial. So as per the bleeding risk and the risk factor they have mentioned. Next slide. So coming to our patient's profile based on Compass inclusion criteria, the patient must meet the criteria for CAD and PAD or both. The Compass trial, the CAD patient, the criteria for CAD was previous MI within last 20 years, multivessel CAD with history of stable and or unstable angina, multivessel PCA or multivessel CVG. Patient with CAD must meet at least one of the following: age must be more than 65. If less than 65, then it should be more than 2 vascular beds or 2 additional risk factors like smoking, diabetes, eGFR. So these are the CAD criteria. And there is the PAD criteria like previous revascularization, previous limb or foot amputation, intermittent claudication in the following of in more of the following with ankle and arm index of BP ratio of less than 0.90. Significant peripheral artery stenosis that is more than 50% documented. Previous carotid revascularization, and so these are the PAD criteria. So the COMPASS trial, the cardiovascular outcome for patients using anticoagulation strategies, they studied around 27,000 patients with stable CAD, where they randomized with rivaroxaban 2.5 mg with aspirin daily and rivaroxaban 5 mg daily and aspirin 500 mg daily with a median period of 1.9 years. It's the first NOAC and antiplatelet combined therapy trial to demonstrate significant reduction in the MACE in patient with stable coronary artery disease. Again, the stable coronary artery disease is very important here. Next slide. So the main outcome, the MACE with rivaroxaban and aspirin combination was down by 24% with the net benefit of 20% and mortality benefit of 18%. While if we are using rivaroxaban alone, then the benefit is not there. So we have to use it with aspirin. So the primary outcome was 24% lower with rivaroxaban 2.5 mg twice plus aspirin than with aspirin alone, 4.1% versus 5.4%, demonstrated graphically. Next slide. So COMPASS is a landmark trial. Again, some selected outcomes are mentioned, like cardiovascular death, stroke and MI, and secondary outcomes. Next slide. So clinical implication of this trial was that switching from dual antiplatelet therapy to dual pathway therapy, like dual pathway means rivaroxaban plus aspirin, and therapeutic use and clinical benefits of dual pathway therapy in both CAD and PAD patients. In 2019 NICE guidelines, rivaroxaban plus aspirin is recommended as an option for preventing atherothrombotic event in adults with CAD and symptomatic PAD who are at high risk of ischemic events. So these are the NICE guidelines. So to conclude, COMPASS is the landmark only trial which has been done with rivaroxaban and aspirin and has showed significant 24% benefit. Like equivalent to undergoing a procedure. And in long term, let's see how this works there. Practically, personally, we have started using this combination. The more the experience along with we have, the more the confidence we have in this combination. Over to you.
Are you done?
Yes, sir.
Yes, nicely you have told about the newer concept, which is dual pathway inhibition, in which we don't not only target the antiplatelets but also take care of the thrombotic pathway also, because it has been seen that over the years the thrombin generation is there, and whenever the patient passes from acute phase to chronic, initially there is a platelet hyperreactivity. With time, after 9 months to 1 year, the platelet will become normal, and then only the thrombin generation is there because of some event, some trauma or some inflammation which need to be taken care of, and that is why antithrombotic inhibition along with antiplatelet therapy has come into picture. And COMPASS trial had shown that if we combine a low dose rivaroxaban with aspirin, it shows a quite good benefit over long term period, and the benefits add on, and as the COMPASS was done for 3 years, the benefits cumulated. That means every year the benefit were add on to the earlier benefit what were observed in the previous years. That means if you give this duration for 5 years, the benefit will be much more than for 3 years or 2 years after starting this dual pathway inhibition drugs. Now, Amar, if like your patient is 69-year-old, what was the age?
Yeah, around in 60s he is.
60s, right. Suppose the patient after starting with rivaroxaban bleeds, what will be your strategy then?
We have to withhold a drug, and if this is the minor bleed, it should if not life-threatening. With the lower dose, we rarely see, even with NOACs, we rarely see some major bleed. If minor bleed, it can be tackled, and if there's a major bleed, then we have to provide the FFP and cryoprecipitate, and let's see how the response is.
Sure. No, my question was that what will you do with NOACs? Suppose it was not a major bleed, it was just some bleeding in the stools. Then what will you do?
Then definitely we'll put him on again the single antiplatelet to avoid further events in future.
So that the point of discussion which we have also discussed in some other meetings as well, that it is basically the aspirin which is the culprit usually with GI bleeds, but
right.
But we all know that anticoagulants bleed much more than antiplatelets, right?
Exactly.
So whenever you have this kind of subset in which you have started with dual pathway inhibition. Patient have minor or not major bleed but recurrent bleed. Then definitely you have to stop the antiplatelets, the anticoagulants. And for
Right.
antiplatelets, you can give clopidogrel, which is safer for GI as
Safer
compared
than
to
aspirin, definitely. Yeah.
Second is, if the patient has just one episode, then you can, for some time you can stop rivaroxaban, and after some time you can start rivaroxaban in the same 2.5 milligram BD dose, and instead of aspirin you can do clopidogrel. We don't have the trial data to suggest this, but this is like a expert opinion that for GI safety you can try this as well. But if the patient has a recurrent bleed, then you have to stop rivaroxaban and have to shift on clopidogrel, because clopidogrel has been seen to be safer and almost effective as compared to aspirin for GI bleeds. This is one part. Second is, suppose if the patient is on this dual antiplatelet dual pathway inhibition and patient gets MI and requires angioplasty, then what will be your approach?
Again, we will have to we will like to stop rivaroxaban and load the patient with another antiplatelet and then go for the procedure there.
And then will you start again rivaroxaban?
After 1 year at least. After he reaches the stable coronary artery disease phase.
Right. Like I said, that whenever there's a platelet activity, we require two antiplatelet agents, and especially for stenting, we don't have any data with NOACs or vitamin K antagonists because the bleeding risk is quite high. So we only rely on dual antiplatelet, especially ticagrelor with aspirin, which is a preferred combination worldwide for post-stenting period. And that too for 1 year, we need to be relying only on dual antiplatelet. We do have now data from this TICO trial and Twilight trial that after 3 months also aspirin can be stopped and we can just continue with oral the single antiplatelet agent. Like in your case, if the patient is high risk for vascular events, then definitely after 3 months you can consider adding rivaroxaban with a single antiplatelet agent. And experts' opinion is again is divided. That some says that we cannot stop ticagrelor after 3 months, like whatever the TICO and the Twilight trial have shown, and with ticagrelor they start with rivaroxaban. But some people say that you just give dual antiplatelet for 1 year and then you shift on to aspirin with rivaroxaban. So that is individual choice, whatever you decide. But more importantly, whenever the plasty is done, what emphasis is on the type of stent. What have you used? It is a double second generation stent or the first generation stent. The length of the stent, the complexity of the angioplasty, the bifurcation, CTO. The patient had a subset of MI before. If it is a chronic stable angina, single small length stent, everolimus lifting stent, later generation, then definitely safely you can shift the patient after 3 months to a single antiplatelet agent depending on the patient's subset, and then you can add rivaroxaban depending on the patient's clinical profile. If the patient has a history of peripheral vascular disease or stroke, much more, like he had a previous issue of stroke, he have amputation done before, or he have a claudication with a documented peripheral vascular disease, then we more rely on rivaroxaban with a single antiplatelet agent for the simple reason we don't have a data with or the trials with dual antiplatelet agent in peripheral vascular disease or in stroke patient. And one important point of stroke was that in this COMPASS trial was that there was around 54% reduction in stroke, in the occurrence of stroke in COMPASS patient, which was much more than having a cardiovascular event. Do you know this? The stroke was prevented much more in COMPASS trial patient when they were followed. That means when we give this dual platelet inhibition, stroke prevention is a much important factor. So this also helps in our patients of this peripheral vascular disease with vascular disease. I won't say coronary artery disease, but vascular disease, because whenever you have 2 beds involvement of atherosclerosis in vascular bed, then you give this dual pathway inhibition. Third point is that the Voyager peripheral artery disease trial, Voyager PAD trial, have clearly shown that the adding rivaroxaban with aspirin have decreased the incidence of getting amputation or surgery to 50%. That means when we add rivaroxaban with antiplatelet, the efficacy is much more and beyond the cardiac events. That means the stroke prevention is higher, the peripheral disease prevention is quite better as compared to single antiplatelet, or for that case dual antiplatelet also. So whenever you have a subset, you always weigh the risk of bleeding versus the way of having a events, stroke, cardiovascular events, or peripheral vascular disease, depending on the patient subset. Then we decide that whatever the patient's inpatient benefit will be the scenario, whether we continue with the dual antiplatelet or single antiplatelet with the rivaroxaban. Second point which I want to stress, that only rivaroxaban is the molecule apart from dabigatran or apixaban in which trial has occurred in chronic stable angina patient also, but none of the molecule except rivaroxaban have shown promise or benefit in the trials. Newer trials are being conducted, but at the moment the data, and of course only with the compass what we can safely prescribe, that this is the only rivaroxaban is a molecule in which we are sure or confident when we prescribe this patient to prevent a good long-term outcome, and we should go with the scientific data what we have. Some doubt was there that patient may bleed again with that, but just leaving that thing, the data what we have, the compass trial clearly says that the event rates is quite less as compared to single antiplatelet agent versus rivaroxaban plus aspirin. So we should stick to this dual pathway inhibition strategy, and with the patient in the chronic stage, we should prefer this dual medicine versus single antiplatelet agent. And after 1 year of angioplasty, we should try to shift the patient on rivaroxaban by stopping a dual antiplatelet. I think you must be doing the same thing at your setting also, that after 1 year of angioplasty, you must be shifting to single antiplatelet agent, isn't it?
Yes, we are shifting to
so
single
now what we have
antiplatelet.
started is that along with aspirin, we also give a low dose rivaroxaban to give the benefit of prevention of cardiovascular events like stroke and peripheral vascular disease.
Right.
Anything else? Anybody wants to add to this?
No, sir. So there is no any question as such from the audience as well. So,
I will like to thank Dr. Amar, Dr. Deepak, Dr. Wag for their nice presentations, and thank you, MCure, for giving us this opportunity.
Yeah, sir, even on behalf of MCure, we are thankful to all our speakers today, Dr. Amar, Dr. Deepak, and Dr. Rajesh Wag. And we are grateful, sir, for your role as a course moderator, nicely directing throughout the course regarding the wonderful discussion, followed by each case presentation. So with that note, and with the hope of meeting with the next event in a successive or upcoming months, I would like to thank all the faculty again, and also all the viewers who are watching us this event, this live workshop with us. So before concluding, I would like to convey the message to my colleague to play a 1 minute quick video, which is all about the molecular development of this rivaroxaban at the MQ facility. Over to Mr. Ravi for playing the video, and we will stop with the video. Thank you.
Thank you, Dr. Deep, and I request RX event to play the video.
Do you know which Indian pharma company has consistently launched innovative first in India products? Presenting MQ Pharmaceuticals. With over 500 scientists, we are pioneers in chirality. We have been making a healthy difference to countless families. With cardiology at our heart, we have strived to give you better products always. Chiral products are complex to develop. They are difficult to manufacture, but their benefits make a difference. A difference for your patients, for you. We are proud to launch our latest chiral development, Exafib, our indigenously developed rivaroxaban. Developed in-house, manufactured at our state-of-the-art facility at Jammu. This is a WHO GMP certified facility. We conduct quality checks to ensure only the best is delivered. Exafib complements our chiral cardio portfolio. Exafib committed to make a difference in anticoagulation therapy for your patients.
Thank you, sir. Thank you so much. I'm very glad.
Do you know?
To inform everyone that Exafib is #1 brand, in all India as per the MAT. And also it is a #1 brand in Maharashtra, and that is a support and help on and believe on Exafib. So I request all the doctors to please continue your support and trust on Exafib. So with this, on behalf of Acute, I would like to say thank you so much to our moderator, sir, Dr. Gaurav Verma, sir, and nicely conducted today's session. Even in the because of some unfortunate event, Dr. Glasmother sir has not joined, and still Dr. Gaurav Verma sir handled very nicely and given very good feedback and very suggestions, and that would be really helpful for all delegates, those who joined today. They have learned a lot today from today's our discussion and the presentation. So I would love to say thank you to Dr. Gaurav Verma sir and all the three speakers. Thank you, sir, and good night.
Thank you, Ravi. Thank you, Emker. Bye. Good night.